Across all of oncology, one of the more interesting group of drugs that have emerged in recent years are the antibody drug conjugates. There are many of them. They're in use now in various types of cancer, but they have in common an antigen binding site, a monoclonal antibody that targets a tumor-specific or tumor-associated antigen, stable linkers that link the antibody to a potent cytotoxic payload, allowing the payload only to be released when it is within the cancer cell, the true dream of the magic bullet in oncology. For a number of years now, we have had a first-generation antibody drug conjugate available for the treatment of metastatic HER2-altered breast cancer, and the drug, of course, is T-DM1, which had prominent activity following failure of first-line treatment based around trastuzumab or trastuzumab and pertuzumab. Unfortunately, even with a good drug like T-DM1, relapse resistance is the rule. And it's been very exciting recently to find that there is another drug which has emerged in this space, which appears to have activity even following T-DM1 failure. And that drug, of course, is trastuzumab deruxtecan. This, again, is an antibody drug conjugate with a potent payload, but it may have certain advantages over T-DM1. The cytotoxic payload is a topoisomerase 1 inhibitor, which is a derivative of exatecan. It's got a very high drug-to-antibody ratio, which is higher than that which is seen for T-DM1. It also has a stable linker payload, a tumor-specific cleavable linker. It is a high potency, it's membrane-permeable payload with a short systemic half-life, which is critically important. It also has the ability to have a bystander killing effect. Trastuzumab deruxtecan had a very stern challenge in its first large-scale breast cancer study, which was called the DESTINY-Breast01 trial. This was a trial conducted in heavily pretreated patients with HER2-altered breast cancer. These patients had up to 6 lines of prior therapy. They all had prior exposure to T-DM1. The study included an early pharmacokinetic phase, a dose-finding phase, and ultimately an expansion cohort, leaving us in the end with 184 patients evaluable for activity. The dose which was studied for efficacy in the DESTINY-Breast01 trial was trastuzumab deruxtecan, 5.4 milligrams per kilogram. It was extremely active in this heavily pretreated cohort of patients, with an objective response rate of over 60%, including 6% complete remissions and approximately 60% partial responses. In addition, approximately 1/3 of the patients had stable disease. Remarkably, only 1.6% of patients had progressive disease, and the disease control rate was approximately 97%. The 6-month clinical benefit rate was approximately 76%, and the median duration of response was over 14 months. Importantly, the drug acted relatively quickly, and the median time to response was less than 2 months. I think graphically, one of the most dramatic ways of seeing these results is to look at the waterfall plot, which really is quite one of the most remarkable plots that I have seen with any new drug in oncology. The great majority of patients had some degree of shrinkage of their cancer. This slide depicts the progression-free survival curve for patients on the DESTINY-Breast01 trial. And as you can see, it exceeds 16 months. Of course, for those of us involved in clinical and translational research in breast cancer, I must say it's been a particular joy seeing the improvements which have occurred in HER2-altered disease. In nature, this is probably the worst type of breast cancer, but the results which have been achieved through new therapeutics have really transformed the landscape of the disease, both for patients with early-stage disease and those for metastases. We're seeing some patients achieving long-term durable remissions of metastatic disease, possibly even cures. We're seeing improved survival for other patients with metastatic disease. But sadly, most patients who develop HER2-altered metastatic breast cancer at this point in time will still die from breast cancer. And that is why it is critically important that these new advances translate into widely available drugs. We do understand as oncologists that while we have our own patients' best interests at heart, we do practice within a societal and economic context. But it is, I must say at the moment, quite frustrating to see several really promising new drugs prominently trastuzumab deruxtecan, producing extraordinary results in heavily pretreated patients and not having routine access to them. I'm involved in several initiatives. I founded the Irish Cooperative Oncology Research Group, which is now called Cancer Trials Ireland, which conducts large-scale clinical trials in Ireland. And also, I was the founder and lead a consortium called Molecular Therapeutics for Cancer Ireland, which is very focused on translational trials, niche trials, novel therapeutics, trying to match the right drug to the right molecular or immunological target. And we've had a substantial focus on HER2-positive metastatic breast cancer over the years, and I believe it will continue in the next few years. It is my personal dream that we will see the cure rate of HER2-positive metastatic breast cancer increase. I believe some patients are cured now, but I think even with the drugs we have available to us now, there's every prospect that we can see major improvements as we develop them. Thank you very much for your attention. I hope you're all staying well and safe with the pandemic. And with that, I have great pleasure in handing back over to my colleague and friend, Dr. Sarah Hurvitz at UCLA.
Thank you, Dr. Crown. I share your enthusiasm for trastuzumab deruxtecan. I just want to expand a bit on the bystander effect that you briefly mentioned. Trastuzumab deruxtecan is a unique antibody-drug conjugate. In distinction to TDM1, trastuzumab deruxtecan has a cytotoxic payload that is membrane permeable. So when it has attached to and gone inside the HER2-expressing cancer cell, the payload is released and it's able to leave the cancer cell and kill nearby neighboring cancer cells that may have less expression of HER2. This may expand where we're able to use T-DXd in a new class that's being defined by low expression of HER2. Also, a question that comes up frequently is whether or not T-DXd can be used as an earlier line of therapy. In fact, there are ongoing clinical trials in the phase 3 setting that are looking at T-DXd against TDM1 in the second-line setting, phase 3 trials looking at T-DXd versus standard of care capecitabine plus trastuzumab and lapatinib in the third-line setting, as well as looking at the use of T-DXd in the early stage setting and in HER2-low metastatic breast cancer. So in the next several years, I think it's going to be very exciting for us as many of these studies report out. So returning to our patient, Grace, she does respond to T-DXd. Her liver lesions respond very nicely. And importantly, she reports no cough, no shortness of breath, or fever. These are very reassuring findings. So let's now go to Dr. Carlos Barrios in Brazil to find out why the lack of these symptoms are so important with T-DXd. Carlos?
Thank you, Dr. Hurvitz. That's certainly an important point. And here you can see the adverse events that have been associated with T-DXd. Here you can see that the most common adverse events are nausea, vomiting, diarrhea, constipation, decreased appetite. Some patients also complain of fatigue, alopecia, cough, and importantly, anemia, neutropenia, leukopenia, and thrombocytopenia have been reported. Very importantly for everybody to recognize, severe, life-threatening or fatal ILD, including pneumonitis, can occur with T-DXd. The management of these adverse events is something we need to pay attention to. We need to monitor CBC prior to initiation of treatment and prior to each dose, and obviously as clinically indicated. Very importantly, we need to monitor for ILD and pneumonitis during treatment. And as we do usually with oncology drugs, management of adverse events may require temporary interruption, dose reduction, or even discontinuation of the drugs at certain times. On the same note, it's critically important for everybody to understand the strategies to manage ILD, particularly the one associated with DXd. We need to monitor patients and promptly investigate any sign or symptoms of respiratory problems, particularly cough, dyspnea, fever, and any other new or worsening respiratory symptom. We need to evaluate these patients with imaging, and we need to consider pulmonology consult in those situations. Importantly, for patients that have asymptomatic ALD, we need to hold the TDXD and repeat the imaging within 4 weeks. We need to consider corticosteroid treatment if necessary, and once resolved, we can start TDXD again, but with dose reduction. Just in the case of patients with symptomatic ILD, we need to discontinue TDXD and initiate steroids, considering a pulmonary consult in that situation. So now that we have talked about the antibody-drug conjugates in the HER2 arena, let's look at the TKIs that have been approved in 2020, starting with neratinib. Neratinib, that had previously been approved in July of 2017 for early disease, and now in February of 2020 was approved for HER2-positive metastatic breast cancer. And most recently, tucatinib was approved by the FDA in April 2020 also for metastatic disease. So neratinib was approved for metastatic HER2-positive breast cancer on the basis of the NALA trial. The NALA trial included patients with centrally confirmed HER2-positive metastatic breast cancer that had previously been treated with 2 or more lines of anti-HER2 therapy. Patients were randomized to neratinib and capecitabine versus lapatinib and capecitabine and were treated until progression of disease. There were 2 primary endpoints in the NALA trial: overall survival and PFS, and a number of secondary endpoints. The study was to be considered positive if either of those 2 co-primary endpoints were statistically significant. And here you have the results of the NALA trial for the 2 primary endpoints of the study. And you can see that the PFS had a modest 2.2 but significant benefit favoring the combination of neratinib and capecitabine versus lapatinib and capecitabine. As you can see, there was a numerical improvement in the overall survival that didn't reach statistical significance. Very importantly, we need to recognize and manage the side effects associated with neratinib and capecitabine. And here you see a list of the adverse events that have been reported most frequently with this combination of neratinib and capecitabine. Weight loss, constipation, problems with appetite, fatigue, asthenia, vomiting, nausea, and obviously diarrhea, which is of major concern with the use of neratinib. The management of this situation is extremely important. Antidiarrheal prophylaxis should be given to all patients and should be initiated with the first dose of neratinib. If even with that prophylaxis diarrhea occurs, other measures should be implemented with other antidiarrheals, fluid administration, control of electrolytes as clinically indicated. Neratinib should be permanently discontinued in patients experiencing grade 4 diarrhea. The same thing needs to be done. We need to follow carefully liver function tests, and neratinib should be permanently discontinued in patients with grade 4 or higher liver abnormalities. Another important information from the NALA trial, and that was one of the secondary endpoints of the trial, looked at the intervention that was performed for patients with CNS disease. And as you can clearly see in these 2 curves, neratinib delayed the intervention for CNS disease. That's something that has significant clinical consequences and should be recognized as a positive effect of the drug. So before we continue with our case, let me take a few minutes to tell you about how do we manage breast cancer in Brazil and in Latin America in general. Let me tell you that we follow international treatment guidelines such as NCCN and ABC. Some local guidelines are also in place. And most oncologists are familiar with these guidelines across the region. Importantly, we need to recognize that the available resources are unevenly distributed within Brazil, and this is true also across Latin America in general. Access to recently approved therapies, and even sometimes to basic double blockade with trastuzumab and pertuzumab, is limited in many countries, and many patients do not have access to these treatments. Dealing with these discrepancies remains the main challenge in the region. Lack of investments, unequal resource allocation, delayed approvals, and lack of established cancer care plans represent, in my opinion, the ongoing major priorities to be tackled in this situation. We need local efforts to improve access, added to international collaboration, as many of these problems and challenges are shared by the other countries as well. And this demands an open dialogue among the different involved shareholders. The appropriate solutions for these problems will only come for a very involved collective construction process. Patient and society participation is absolutely essential. And with that, back to you, Dr. Hurwitz, in Los Angeles.
Thank you, Dr. Barrios. Before we continue, I have a question for you. We know the clinical presentation and imaging findings for ILD associated with TDXD can mimic those of COVID. How does this impact the way you work up and manage someone who's presenting with pulmonary symptoms while receiving this drug?
This is a very interesting and very important question. Actually, the management of ILD is a challenge, and is something I usually say is an internist problem because of the number of differential diagnoses to be considered in this situation. The COVID situation we're all living throughout the world adds another differential diagnosis to be considered in these patients. So essentially, the idea here is to remember and recognize that ILD can be associated with TDXD and some of the other drugs that we're using in general. And we need to run this differential diagnosis. And not unusually, we need to call for a pulmonary consult in terms to help us in managing this kind of situation.
Thank you, Carlos. I agree that a pulmonary consult is a prudent decision nowadays. Okay, let's get back to Grace, and this is a what-if question. So what if Grace developed new brain lesions while she was on TDM1, and despite initial radiotherapy to the brain lesions, she had progressive disease in the brain? In that scenario, which option would have been best for her? Let's go now to Dr. Chan in Australia. Arlene?
So thank you, Sarah. We are fortunate these days to have some very good options that we can consider, including tyrosine kinase inhibitors such as tucatinib. And let me explain to you some of the recent data that has come through the reporting from the HER2 CLIMB study.
When the question appears, select your answer and then proceed by following the directions on your screen to resume the presentation.